Welcome back. This is Dr. Pasion-Gonzales, and this week we are studying Chapter 14 on psychological disorders. So we're going to study Chapter 14 over 2 weeks. So this first week is going to be from sections 14.1 to 14.8, and our discussion today is going to be on the mood disorders and anxiety. Now, it's important to appreciate that psychological disorders are viewed very differently today than they were in the past. To be diagnosed with a psychological disorder these days requires meeting certain specific criteria in terms of observable symptoms or symptoms that are reported by the person. Also, these collections of symptoms create some distress or difficulties in the person's life that interferes with normal functioning. From the chapter, be sure you understand the difference between a psychological disorder or mental illness versus insanity, which is a legal term. I also think that the working definition of abnormality in section 14.1 is a helpful construct for understanding the global impact of psychological disorders on a person who has them. For example, clinical depression is more than just feeling really, really sad. There's a global impact on nearly every area of a person's life: emotional, mental, physical, relationships, motivation, everything. It's so much worse than just, man, I feel really, really sad. In reading through sections 14.2, models of abnormality, I found myself thinking about different kinds of problems that could fit under any of those headings, whether it's from a biological perspective, a cognitive perspective, behavioral perspective, even psychodynamic. So I think the question here to ask yourself isn't which perspective is correct, but which model is most helpful in understanding what most contributes to the person's difficulties to help identify how best to help them. For mental health professionals these days, we use the DSM version 5, the Diagnostic and Statistical Manual for Mental Disorders. And we use this for diagnosing psychological disorders. It is the standard of how we define what a psychological disorder is. For example, in early versions of the DSM, because now we're up to version 5, homosexuality was considered a disorder. It was actually listed as a psychological disorder. And in the more recent versions, it is not considered a psychological disorder at all. But I want you to understand that this DSM, that this manual, has a tremendous influence on how we define, how we look at, even what we view to be a disorder or not. In section 14.3, I found the statistics on disorders pretty interesting, especially figures 14.2 and 14.3. These two figures give a nice overview of the different disorders and a breakdown by ethnicity and gender. In table 14.1, I want you to notice how statistically rare it is for someone to be diagnosed with schizophrenia, which is about less than 1% of the population, and bipolar disorder, which is less than about 3% of the population. These are talked about quite a bit, but the various kinds of anxiety disorders tend to be the clear front runner in terms of prevalence in the US. So let's start with depression. Now, the term major depressive disorder is a clinical term based on the DSM-5. To meet criteria for major depressive disorder, a person must have at least 5 of 9 specific symptoms, and these symptoms include depressed mood, feeling sad, loss of interest or pleasure in doing things. We call this anhedonia. Significant weight loss or weight gain. Insomnia or hypersomnia, meaning you can't sleep at all or you're sleeping way more than is normal for you. Psychomotor retardation or agitation. So a person with psychomotor agitation is moving around a lot. They can't sit still. They're very active, just pacing and just moving all the time. They can't sit still for anything. A person with psychomotor retardation is just the opposite. If you ask them, how are you feeling? They might go, how am I feeling? Well, I guess not too good, right? So it has to do with how slow or how ramped up their physical movements are, okay? Fatigue, feeling tired, feelings of worthlessness or excessive guilt, decreased concentration, or thoughts of suicide and death. So the person has to have at least 4 of those 9 symptoms, but not all of them. In addition, all of these symptoms must cause significant distress or impair the functioning in different areas of their life, at work, at school, the relationships, things like that. So it has a direct impact on their life. In addition, this depressive episode is not the result of substance abuse, like alcohol, marijuana, heroin, cocaine, things like that, or another medical condition. For example, thyroid problems can really slow down your metabolism and can look like depression. And the depression can't be better explained by another psychological disorder, right? And lastly, there's no history of a manic or hypomanic episode. And we're going to talk about that in a second. So for major depressive disorder, it's a clinical term, and it's a whole lot more than just having a really, really bad day and feeling super sad. Now, for the test, you're not going to need to know the DSM criteria for major depressive disorder, but I do want you to appreciate that there are very specific criteria that we use to make the diagnosis. In the book, figure 14.5, I think gives a really helpful picture of suicide rates in the US by ethnicity and gender. In section 14.4, I thought it was interesting that although major depressive disorder is more common among women than men, there's some studies that are starting to show that gender differences are virtually non-existent in college students and young adults. Now, this is really interesting to me. And so in your discussion board, I would be very curious if you have a thought or a conjecture about why that might be. Now, there are other types of depression as well, such as dysthymic disorder or persistent depressive disorder. That's the other more current name for it, which is really best described as a low-grade persistent depression. There's also postpartum depression. And when a person has depressive symptoms, but they don't fit cleanly into any of those diagnostic categories, we can give them a diagnosis of depressive disorder unspecified. Now, sometimes the depression can be so severe that the person actually experiences psychotic symptoms, such as hallucinations, like hearing voices that other people don't hear. And also they can get delusional, like paranoid. Now, the interesting thing is they're not psychotic all the time. They only have these symptoms when the depression really, really, really hits them hard. Okay. Now let's talk about bipolar disorders, which used to be called manic depression. There are a lot of misconceptions about what a manic episode looks like. So sometimes people will come into my office and they're worried that they might have a bipolar disorder, and I'll ask them why, and they'll tell me because their mood shifts so quickly. They can get angry and then sad, then okay, and then irritable again, just at the drop of a hat, multiple times a day. And the good news is we call this labile mood. Labile mood, mood switching very quickly from one to another, is not a mood swing. And this labile mood is very common when you're frustrated, when you're feeling sad, discouraged, fatigued, stressed out, and about 10 other reasons, okay? This is a very, very normal shift in mood. This is not what we're talking about with a manic episode. For a bipolar disorder, the mood swing or manic episode can last days and even weeks, and the person has to have 3 or more of very specific symptoms during that same time period. So these symptoms have to be very different from the person's normal functioning. These mood changes have to be present for at least a week in order to be considered a manic episode. Inflated self-esteem or grandiosity. For example, I had a person tell me once that they were such a good golfer. They're probably the best golfer that I've ever seen. They should be on the PGA Golf Tour. But this person only thought that when they were manic. Second, there's a decreased need for sleep. Now, this isn't like a person can't sleep. This isn't insomnia. This is the person who they're getting 3 or 4 hours of sleep for several nights in a row. And if you ask them, man, aren't you exhausted? They go, no, you can sleep when you're dead. I got nothing but energy, man. I feel great. Okay, so it's not they can't sleep, it's a decreased need for sleep for a short period of time. The person can be quite talkative or pressured speech. They're talking a mile a minute, and it feels like you can't even get a word in edgewise because they just have to. There's this pressure to just talk and talk and talk and talk. Racing thoughts is another potential symptom. They can be easily distracted, and an increase in goal-directed activity or psychomotor agitation. So they might be walking around their house at midnight and go, you know what? I think I need to paint the whole house. Yeah, I'll do that. And actually get around to doing that. And lastly, they tend to engage in activities that hold potentially painful consequences. They might spend money they don't have. They might sleep with people who they would never dream of sleeping with otherwise. When they come out of the manic episode, they have a lot of regrets about some things that they've done. Their mood is elevated, expansive, or irritable. Now, for a hypomanic episode, all of the same symptoms are there. The big difference is it only lasts for 4 days instead of a week. So if you have all of these symptoms, but just for 2 days, that's not considered a hypomanic episode. It has to be for between 4 to 7 days. For a full-blown manic episode, it has to be at least a week. Now, one of the big snags with diagnosing bipolar disorder is that some of the symptoms overlap other disorders. So, for example, a person can have delusions or hallucinations, and these psychotic symptoms can be present in a manic episode, in schizophrenia, or even drug use, or when the depression is really, really bad. So we have to go deeper to try to sort out where the symptoms best fit. With psychomotor agitation or pressured speech, right, which are symptoms of a manic episode, those can also be present with certain types of drug use, like stimulants, like cocaine and methamphetamine, but also anxiety or stress or ADHD. So because manic episodes can look like other things, it's important to consider the stability of the symptoms versus the episodic nature of the symptoms. So if someone's thinking is pretty grandiose, they're talkative, have lots of energy, have persistent sleep problems, that's not necessarily a manic episode. To meet criteria for a manic episode, the symptoms only occur for a week or longer. If these symptoms occur all the time, it's a big problem, but it's not going to be a bipolar disorder because it's not a manic episode. As a medical provider or a mental health provider, it's easier to pick up that the depression is present, but it's pretty simple to miss the diagnosis of a manic or hypomanic episode. So a proper diagnosis of a bipolar disorder can sometimes be tricky and is often missed. Now, the biggest problem with this is the medications that you use for regular depression can actually send somebody into a manic episode if they've got a bipolar disorder. So getting the proper diagnosis is a really, really, really big deal. Just so you know, we have quite a bit of research that all suggests that bipolar disorders are absolutely worsened when you introduce alcohol and drugs into the mix, even marijuana. This was the topic of my dissertation about 1 million years ago. So when you introduce alcohol and drugs to someone who has a bipolar disorder, the research shows that there's an earlier onset of symptoms, more hospitalizations, and a poorer response to treatment. So it's a really, really big deal that someone with a bipolar disorder be clean of alcohol and drugs and take their medications regularly. And speaking of medications, this can be a real issue. What happens for a lot of people is they'll have a manic episode and their life will be just really, really rocky. They'll get on the right medications and their life stables out. They're doing pretty well. So they're doing well long enough where they start to think, well, why do I have to take medications if I'm doing pretty well? So they'll get off the medications and then everything starts to get very rocky again, right? And so then they get back on their medications and then they staple out. And after a while, they go, well, okay, maybe I'm better this time. I don't need the medication anymore. So that's a very typical pattern. And this is problematic because every time a person has a manic episode, they tend to last longer. They tend to get more intense and they're harder to treat. So we really want to minimize the number of manic episodes a person gets during their lifetime. Okay, let's talk about anxiety. Now, there are a number of different anxiety disorders, including specific phobias, generalized anxiety disorder, and panic disorder. And I think the book does a pretty decent job of describing the phobias. I think most people have some degree of social anxiety, but that's not enough to meet the criteria for a formal diagnosis. Now, with panic disorders, what happens is there's a sudden onset, seems to come out of the blue, where there's psychological, emotional, and mental symptoms that hit all at once. It's very common to experience heart palpitations where it feels like your heart is pounding out of your chest or racing a mile a minute. Uh, your breathing can get very shallow and rapid. People can get dizzy or lightheaded. There's sweating involved. You might have some GI issues, so might get an upset stomach. Very intense fear, of course, and sometimes even numbness in your hands or your feet. Now, on average, these symptoms last 10 to 15 minutes and very rarely more than about 45 minutes. It is extremely common to wonder if you're having a heart attack or a stroke. So people often go to the ER, sometimes several times, for fear that they're dying right there on the spot. I've had people sheepishly admit to me that they've said goodbye to their family when they have a panic attack because they were convinced they were going to die. However, there's three really important points that I want you to understand about panic attacks, and they're all good news. First of all, panic attacks are absolutely non-lethal. There is not one single documented case of anyone ever dying from a panic attack. It does not happen. In fact, people don't even pass out from panic attacks. Now, in the 25 years that I've been doing therapy, I haven't even had anyone tell me that they've been in a car accident because they've had a panic attack while they're driving. Okay? So they're very, very safe, even though they're absolutely terrifying. Second, panic attacks are time limited. They always stop, right? So they start, they build up, they peak, 5, 10, 15 minutes, and then they always resolve. They always go away. Number three, panic attacks have a random nature to them. Our amygdala tries to associate the place or the situation where we've had a panic attack to avoiding some of those places, like a Walmart or large crowds, things like that. And so we feel afraid that those situations or places will trigger another panic attack. So when we start avoiding these places or situations for fear of having a panic attack or fear of we're not going to be able to have an easy escape if we need it, we call that agoraphobia. So people can have agoraphobia with panic attacks and also without panic attacks. So these 3 points are really, really important because it sets the foundation for how we manage panic attacks. This is why we can say, write out the panic attacks as comfortably as you can. That's the goal. And we can say this because you have to trust that the panic attacks are not going to kill you and it's going to stop in a few minutes. So avoiding anxiety-provoking situations actually has this paradoxical effect of making the anxiety worse over time, not better. Because what happens is you never get a chance to practice writing out that anxiety until the anxiety resolves on its own. With the amygdala, right, it doesn't care about reason or logic. You can't just talk your amygdala into calming down. It doesn't work that way. It only learns from experience. So if we never stay in a Walmart long enough until the anxiety subsides on its own, usually about 10 or 15 minutes, our amygdala will continue to fire the alarm because there's nothing to tell it otherwise. There's no successful experiences to tell it otherwise. All right, generalized anxiety disorder. Think of this as more of a pervasive anxiety and worry that is not necessarily tied to a specific event and is pretty much present all of the time. The person is always anxious, even when they can't tell you why. Now, there will be people who are just genetically more predisposed to anxiety, and you can absolutely train a person to be more anxious depending on their life experiences. As with depression, there are both environmental and biological factors that play a role in anxiety. Table 14.2 summarizes some of the anxiety disorders. Reducing caffeine intake, getting plenty of physical exercise, practicing some relaxation techniques such as diaphragmatic breathing or progressive muscle relaxation, engaging in meditation and mindfulness techniques can help with all types of anxiety. Okay, so obviously there's a lot more to this, but I just wanted to give you an overview of some of the major mood disorders and anxiety. And next week, we're going to review the personality disorders, dissociative disorders, and schizophrenia. So there's not going to be the Canvas exam or the Revel chapter quiz this week. We'll put that off until next week. But you still have the Revel quizzes scattered throughout the chapter, again, up to section 14.8. Be sure to do your discussion board this week. If you need to reach me, you can email me. And I've also got my office hours Tuesday nights at 7 o'clock. We're so close to the end of the semester. So finish strong, focus in, and I'll look forward to talking with you guys soon. All right, bye-bye.